A patient comes with cough. Not just cough. Every morning he brings out large amounts of foul smelling sputum. Sometimes there is blood. This is not just infection. This is structural damage. I am Nabeel. This is Pathocyte. And today we'll understand bronchiectasis. Bronchiectasis is permanent dilation of bronchi and bronchioles due to destruction of smooth muscle cells and elastic tissue caused by chronic infection and inflammation. This is not temporary dilation. This is permanent structural damage. There are two main forces involved. Obstruction of the airways leads to infection. Infection causes damage. Damage leads to further obstruction. Vicious cycle. This brings us to the causes of bronchiectasis. First group includes conditions which reduce mucus clearance, which includes cystic fibrosis, where the mucus is thick, which reduces its clearance. Primary ciliary dyskinesia and Pathogenesis syndrome both affect the functioning of cilia, and once ciliary function is reduced, the mucus clearance is affected. Second group includes severe infections like necrotizing pneumonia and recurrent infections. Third group includes obstruction due to any cause. This can be tumor, a foreign body, or even thick mucus. Immune disorders include the fourth category, which can be rheumatoid arthritis, systemic lupus erythematosus, even post-transplant patients. And in about 50% of patients, no particular cause can be identified. So they all come under idiopathic. Now let's look at the pathogenesis of bronchiectasis. Bronchiectasis starts with impaired clearance of mucus. This may be due to thick mucus as in cystic fibrosis or due to ciliary dysfunction. Impaired clearance of mucus leads to bacterial colonization. This infection triggers an inflammatory response. These inflammatory cells and the enzymes released by them leads to tissue destruction. Thus, the smooth muscle cells and the elastic tissue which supports the bronchi and bronchioles are lost. This loss of support leads to the dilation of bronchi and bronchioles. Later on, repair occurs via fibrosis. But in small airways, this fibrosis can lead to complete obliteration of the airway, causing bronchiolitis obliterans. Bronchiectasis is basically a destroyed airway which cannot clear itself anymore. How does the lung look after all these insults? Let's look at the morphology. Grossly, the cut surface of lungs shows dilated bronchioles and bronchi. Bronchi may be dilated up to 4 times its usual size. Normally, bronchi are not visible grossly near the pleura as they are really tiny. But in bronchiectasis, even the bronchi near the pleura can be visualized. These dilated bronchi are filled with pus. When we zoom into the tissue under the microscope, we see acute and chronic inflammation, along with ulceration of the mucosa, squamous metaplasia, and fibrosis. This brings us to the clinical features. Patients have chronic productive cough, foul-smelling sputum due to infections, hemoptysis due to vessel erosion. Later on, breathlessness and cyanosis can also come. The symptoms are usually worse in the mornings because when the patient gets up, the secretions drain down and starts obstructing the airway. How is bronchiectasis different from other obstructive lung diseases? Bronchial asthma is a reversible airway disease which occurs as a response to allergens. Chronic bronchitis is due to excessive mucus production. Emphysema is due to dilation of the distal part, that is, dilation of the acini. And bronchiectasis is due to destruction and dilation of bronchi and bronchioles due to obstruction, lack of mucus clearance, and infections. Once airway is destroyed, it cannot go back to normal. That is why early control of infections is important. Think at the cell level.